بسم الله الرحمن الرحيم. طلابنا الأعزاء، المرحلة الرابعة والخامسة في جامعة ميزان كلية طب الأسنان. Our lecture today about oral habits. Oral habits are defined as a learned neuromuscular act which becomes unconscious. How to create good habit or bad habit. Oral habit have been described by physiologists and psychiatrists and psychodynamic phenomena. Therefore, this is the combination between the psychologists and psychiatrists and psychodynamic phenomena. Dentists are concerned with the oral habit because of the concerned with the habit because of the determined consequences they have on the orofacial system. These consequences which occur in the orofacial system. The types of the change in the dentition that an oral habit may be caused vary depending on the intensity, duration, and the frequency of the habit. Habit may be result in long-term problem and malocclusion in the primary and the permanent dentition. If the habit was abandoned by age of 3، يعني إذا الهابت كانت حصولها بالage of 3، the malocclusion tend to correct themselves, auto-corrections. Lewis in 1930 and Rakusi in 1959, Dr. Rakusi ولويس. First, we form habits, then they form us cure your bad habit, or they will eventually consecure due to the bad habit. When? متى? Professional evaluation have been recommended for children beyond the age of 4 years old, with the subsequent intervention to seize the habit initiated، حتى يوقف الhabit initiation. Oral habit behavior include digit sucking, pacifier sucking, tongue thrust, mouth breathing, paroxysm, lip sucking and biting, and finally nail biting. What is the treatment for oral habit? The simple approach to habit therapy is a straightforward discussion has been in the child and the dentist. Depending on the willingness of the child to stop the habit, 3 different approaches to treat have been advocated. Number 1, reminder therapy, reward therapy, appliance therapy. Reminder therapy is appropriate for those who want to stop the habit but need some help to stop completely. The reminder must be neutral and not perceived as any form of punishment. Reward therapy. A contact is agreed upon between the child and the parent, or between the child and dentist. Number 2, The contract simply states that the child will discontinue the habit for a specific period of time, and in the return he or she will receive a reward if the requirements of the contract are met. هنا يعني تشجيع ولا reminder بدون punishment وبدون تأنيب يكون a gentle reminder، يعني نقول عليها gentle reminder، والطريقة الثانية هي مكافأة، طريقة انه مكافأة اذا نفذ التعليمات اللي احنا انطيناها ليه. Appliance therapy should only be used where reminder and reward therapy have failed, and the appliance is not punishment but rather permanent reminder. وهاي مثل ما نشوف احنا هنا بالصورة انه كيف انه الجريبت او الواير اللي موجود بالبلت اريا يعتبر فد ستوبر للبوشينج اوف tongue or finger may be put in here in this area. Also here like pumper, nip pumper used also as a habit breaker. The parents and the child should be informed that the certain size effect may be temporarily appear after delivery of the appliance. Eating difficulties, speech problem, disturbed sleeping pattern. Habit discouragement appliance should be left in the month for 6 months، يعني من شهر إلى 6 أشهر. The most important thing to remember about any intervention is that the child must be warned to discontinue the habit for treatment to be successful. Number 1, thumb sucking. A. Phase 1, normal and subclinical significant sucking. Extends from the child's birth about 2 years of age. Start this thumb sucking. The sucking is naturally resolved with no harmful effect. Phase 2, a clinically significant sucking. The second phase extends from the age 2 to the age 4 years old. Temporary changes may be occur which are reversible if the habit is ceased by age of 3. C. Active thumb sucking. Beyond the age of 3 and effect on occlusion and orofacial complex. إذن thumb sucking هو 3 مراحل: phase 1 phase 2 phase 3. يعني ممكن يكون بالphase 1 يكون الأسهل، والphase 2 or الphase 3 اللي هي تعتبر more progression or significance phase. Clinical feature: intraoral and extraoral. Here we can see the clinical feature in this photo. We can see this is scars on the finger of the baby, and also malocclusion in different way, and the scars is very clear. Management. Number 1, physiological therapy. Physiological disturbance refer for counseling from the doctor or dentist. Various aids, study model mirror, etc. may be used in order to assess this case. Children and parents are informed about existing dentofacial deformities and long-term risk of the habit. Patients should be presented without positive mental and visual images of the dentofacial ideal accepted from the habit session. During treatment, adequate emotional support and concern should be provided to child by parents. Here we can see the effect of bad habit. Reminder therapy. Bitter flavored preparations or distasteful agent applied to the finger or thumb, example, cayenne pepper, and new coat should be applied in the morning to evening till habit is broken. يعني نستخدم انه اما الاصبع نغلفه او باي كوت معينه ونستخدم لاذعة طعم لاذع وايجنت، وهذا اللي حتى مجربيه سابقا يعني احنا لمراحل معينة. Ice bandage approach, use of a long sleeve gown. ونستخدم سليف أو هذا أثناء النوم بالليل. Number 3, appliance therapy. Removable appliance palatal grips. الجريبس اللي هي هاي نشوفها الهوك اللي تمنع، مثل نشوفها behind the upper central incisor. Palatal grips, racks, palatal and lingual spur. Fixed appliance, palatal grip, Bulger's appliance, quad helix with palatal grip, and RP, rapid palatal expander, also may be used for this reason. هنا نشوف أنه احتمال يكون الثيرابي باي removable مثل ما نشوف removal أو باي fixed appliance اللي هو يكون العامل المشترك ما بين removable والfixed appliance هو palatal grip and Bulger's appliance quad helix اللي يستخدم للexpansion with palatal grip and rapid palatal expander also used for this. نشوف احنا هنا الكواد هيليكس، هذا الكاست الابيض كيف انه احنا مشكلين هاي الهوك او الواير اللي تمنع بخلف السنترال انسايزر. Pacifier habits. Dental changes created by pacifier habits are similar to the changes created by thumb sucking. Pacifier habits are theoretically easier to stop than digit habits. The pacifier can be discontinued gradually or at one point in the time under control of the parent. In a few cases, the child may be subsequently start sucking a finger or thumb. Number 3, tongue thrusting. Retained infantile swallow and feeding pacifier secondary to the oral habit and macroglossia. Upper respiratory tract infection may be lead due to this bad habit. Clinical features. Addressed posture before and after we can see in this. Extraoral lip posture, speech, facial form, increase anterior facial height, due to the bad habit, while intraorally tongue posture, proclination of maxillary anterior incisor, anterior open bite present, increase overjet and maxillary constriction with generalized spacing between teeth. Careful differentiation must be made among a simple tongue thrust, a complex tongue thrust, retention of infantile swallowing pattern, and faulty tongue posture. Number 1. Simple tongue thrust, defined as a tongue thrust with the teeth together swallow. The malocclusion usually associated with it is a well circumscribed open bite in the anterior region. If there is excessive labioversion of the maxillary, يعني protrusion of maxillary incisor, a treatment of the tongue thrust should not begin until the incisor have been retracted. Number 2, many simple tongue thrusts corrected spontaneously during orthodontic therapy. Step in treatment where it's your tongue. A patient is instructed to put the lip of the tongue at the correct position and swallow with the lip pursed and teeth in the occlusion. The use of tactile signals help the patient understand where the tongue should go. The patient should be instructed to practice correct swallowing and at least 40 units a day. يسوي exercise. B. When a new swallowing pattern has been learned on the consecutive level, it is necessary to reinforce it subconsciously. A flat sugarless fruit drop can be placed on the back of the tongue, and it is held in against the palate in the correct position until it is completely dissolved when a day, and the time should be recorded for that procedure. These steps will correct a large percentage of simple tongue thrust. However, one additional step is sometimes necessary. A placement of palatal grips, as shown in the picture behind the central incisor. If it is not corrected, the condition may have been misdiagnosed and is not truly a simple tongue thrust. Number 2, complex tongue thrusts, defined as a tongue thrust with the teeth apart swallow. The malocclusion in this type, seen with the complex tongue thrust, has two distinguishing features. Number 1, a poor occlusal fit is present with usually a slide into occlusion. Number 2, there is a generalized anterior open bite. Diagnosis from the cast alone. Contrary to popular practice is is advisable to treat the occlusion first. The muscle training when begins is similar to that for a simple tongue thrust with a minor modification. Step 1 of a treatment usually is prolonged. It is always necessary to use step 3 for considerable time must be taken to reinforce the newly learned reflexes. Retained infantile swallow. It is defined as the case persistence of the infantile swallow when past the normal time for its departure. لما نغادر. Occlusion on one molar in each quadrant. راح نشوف occlusion على molar واحد in each quadrant. Strong contraction of the facial muscle during swallowing may require both orthodontist and orthognathic surgery. The retained infantile swallow is a problem in the abnormal neuromuscular development. The prognosis for correction of retained infantile swallow is poor. Mouth breathing habit. Mouth breathing habit developmental anomalies like abnormal development of nasal cavity. Patient obstruction is deviated nasal septum and localized begun tumor. Infection, inflammation of nasal mucosa as a chronic allergic, chronic atrophy, rhinitis, enlarged adenoid tonsil, traumatic injury of nasal cavity. Clinical feature of mouth breathing habit. Adenoid face, long narrow face, narrow nose and nasal passage, short upper lip, nose tipped superiorly, expressionless face, protrusion of maxillary incisor, high palatal valve, increased incidence of caries, chronic marginal gingivitis. We can see these photos. Management of mouth breathing. Number 1, symptomatic treatment. The gingiva of the mouth breathers should be restored to the normal health. Number 2, elimination of the cause. If the nasal pharyngeal obstruction has been diagnosed, then removal of the cause is done by surgery. 3, interceptions of the habit. A, physical exercise. B, lip exercise. Number 4, oral screen. Number 5, correction of malocclusion. Paroxysm. Paroxysm is habitual guiding of the teeth when the individual is not chewing and swallow. Calcifications. Paroxysm during sleep and paroxysm while awake. بالاستيقاظ وparoxysm during sleep. Etiology. CNS. Found central nervous system found in the children when cerebral palsy and mental retardation. Number 2, psychological feeling of hunger and aggregations, hate and anxiety, etc. Number 3, occlusal discrepancy, improper interdigitation of the teeth and lead to paroxysm. 4, systemic factor, magnesium deficiency may lead to the paroxysm. or due to the genetic. Clinical feature. Number one, occlusal trauma, pain in the TMG, trauma of periodontium, masticatory muscle, soreness, and the headache. Management. Preliminary evidence suggests that the juvenile bruxism is a self-limiting condition that does not progress to the adult bruxism. Number one, adjective therapy, psychotherapy aim to lower the emotional disturbance, exercise severe to decrease muscle function. Number two, occlusal therapy by occlusal adjustment, splint, refer to appropriate medication. Lip sucking and lip biting. Lip sucking and lip biting is a very important to men. Conclusion. The identifying and assessment of abnormal habit and immediate and long-term effect on the craniofacial complex and dentition should be made as early as possible to minimize the potential deleterious effect. The orthodontist should be tried initially to break the habit by non-invasive means, and if not successful, then pursuing orthodontic correction. Thank you very much, my student.